Let's jump into rheumatoid arthritis, Chapter 6, Autoimmune Diseases. This is a very common one that we will see a lot in practice. The arth part refers to joints. The itis means inflammation. So rheumatoid comes from rheumatism, which more broadly refers to the musculoskeletal illness. Quick definition is that rheumatoid arthritis is a chronic inflammatory disorder that mostly affects the joints, but can also involve other organ systems like the skin and lungs as well. So let's talk about joints. A healthy joint typically has two bones covered with articular cartilages at the end. The articular cartilage is a type of connective tissue that acts like a protective cushion or a lubricated surface. One type of joint, like the knee, is a synovial joint. A synovial joint connects two bones with a fibrous joint capsule that is continuous with the periosteum, which is the outer layer of the bone. The fibrous capsule is lined with a synovial membrane that has cells that produce synovial fluid and remove debris. The synovial fluid is normally a very viscous, jelly-like substance that helps lubricate the joint. To help serve the synovial cells, the synovial membrane also has blood vessels and lymphatics running through it, and they form this joint space. I'm not questioning you guys on this test about any of these first three slides. This is just a review for us to understand what we're talking about when we speak of the joint space. Rheumatoid arthritis, then, is an autoimmune process that is typically triggered by an interaction between genetic factors in the environment. For an example, a person with a certain gene for an immune protein like the HLA, remember is similar to the MHC, might develop rheumatoid arthritis after getting exposed to something in the environment, like cigarette smoke or a bacteria that goes into their intestine. So you have to have both the genetic predisposition and you have to be exposed to it in the environment. So those environmental factors can cause modifications of our own antigens such as modification of IgG antibodies. We also have things like collagen and vimentin. I'm not asking you about collagen or vimentin. So there is this process here that happens. We're not going to worry too much about that. Meanwhile, due to the susceptibility genes, the HLA, the immune cells sometimes are not clever enough, so they get confused by these changes and they no longer recognize the proteins as self. The antigens get picked up by the APCs, and then they get carried to the lymph nodes to activate CD4, and T helper cells are involved then in rheumatoid. The T helper cells stimulate the nearby B cells to start proliferating and differentiating into plasma cells, which then produce specific autoantibodies against ourself. So we need to have CD4 and T helper cells. And then the T helper cells will also stimulate our nearby B cells, and then we'll start to form autoantibodies. Once there, the T cells secrete cytokines, like interferon and interleukin, into the joint space. That's no good, right? And that causes more recruitment of macrophages into the joint space. These are not where they're supposed to be. The macrophages will also produce inflammatory cytokines like TNF alpha, interleukin 1, interleukin 6, which together stimulate the synovial cells to proliferate. The increase in synovial cells creates changes. They call it a pannus, which is the thick swollen membrane with granulation and scar tissue. So we have modified the joint space by this process. But over time, the damage of the cartilage and other soft tissues will begin to erode the bone. The synovial cells will secrete proteases, which break down the proteins in the articular cartilage. Without the protective cartilage, we get bone on bone and they start rubbing together. The inflammatory cytokines increase a protein on the surface of the T cells known as RANKL, or receptor activator of nuclear factor kappa B ligand. You may hear, I'm highlighting that because down the road in pharm and things like that, you may hear these terms popping up again. So if you hear RANKL, that's something that you may associate with rheumatoid arthritis. But meanwhile, antibodies are entering the joint space, remember, and that's a bad thing. One antibody is called your rheumatoid factor, which is an IgM antibody. Okay, so now we have IgM involved. So your rheumatoid factor is an IgM antibody that targets the constant Fc domain of the altered IgG antibody. So what I want you to know here is that rheumatoid factor is one of the antibodies in rheumatoid arthritis. So if I'm checking lab to try to diagnose someone with rheumatoid arthritis, I may check their RF level. Another antibody is the CCP, which is the citrullinated proteins. When these antibodies bind to their targets, they form immune complexes which accumulate in the synovial fluid of the joints, right? So now we have these immune complexes that are not supposed to be there, and they're accumulating within that joint space within the fluid. Those immune complexes activate the complement system, right? That works to promote and keep it going, the joint inflammation and the joint injury over time. So now we're just this continuous cycle that happens. So rheumatoid arthritis left untreated causes many problems, right? And they get very bad joints and deformity of the joints. So the chronic inflammation causes angiogenesis, or the formation of new blood vessels around the joint, which then allows even more inflammatory cells to arrive. So it is a self-perpetuating process because it's actually creating even more pathways to get there. As the disease progresses, multiple joints on both sides of the body get inflamed and gradually destroyed. But the inflammatory cytokines don't stay just within your tight joint space, right? No. Then they escape through the bloodstream and they will reach extra-articular places, meaning outside of the joint. So an example here is interleukin 1 and 6 travel to the brain where they act as pyrogens inducing fevers. In skeletal muscles, they promote breakdown in and around the skin as well as the visceral organs, so they can lead to the formation of rheumatoid nodules, which are round-shaped collections of these macrophages and lymphocytes with a central area of necrosis and tissue death. The blood vessels can also be affected. So our blood vessels get inflamed, and this makes different forms of vasculitis and makes them prone to developing atheromatous or fibrofatty plaques, which means increased risk for heart disease. So rheumatoid arthritis can be a very devastating disease. Really busy slide here, but I wanted you just to hear it, beginning to put these pieces together of how this disease process works. So in response to our inflammatory cytokines now, the liver also starts producing high amounts of hepcidin. That's a protein that decreases serum iron levels because it inhibits its absorption by the gut, and it traps it into macrophages or liver cells. Meanwhile, within the lung interstitium, the fibroblasts get activated and they proliferate and they cause fibrotic scarring, which makes it harder for the alveolar gas exchange. Also, the pleural cavities can get inflamed and fill up with fluid, so you can get pleural effusions, and sometimes mess with lung expansion. Rheumatoid arthritis typically involves multiple joints, okay? 5 or more symmetrically, meaning the same joint groups on both sides, typically will happen. Not always, but typically. So we have activity changing in the liver. We have activity changing in the lung interstitium because of this autoimmune process. Common affected joints we know are the hands and the feet, right, and the elbows. As the disease worsens, it can affect large joints, also like your shoulders, elbows, knees, and ankles. And when we have these flares, you'll get these really hot, warm, painful, tender joints. People with rheumatoid arthritis can develop specific deformities, such as the metacarpophalangeal joints in the hand, and you get those ulnar deviations of the fingers. The deformities are also common in our interphalangeal joints, and so we get these so-called, what we refer to as boutonniere deformity or buttonhole deformity. Those are questions like that you could see on an exam when you're sitting for certification. You know, if you have a patient that presents to you with these deviations of the fingers and metacarpophalangeal joints, what are they called? And you would say the boutonniere deformity or the buttonhole deformity. I've seen those questions fly around before in other exams. So another finger deformity is the swan neck deformity, which you can see. In the knee, you can get inflammation of the bursa, and you can actually get a Baker cyst from that. Also, though, we have this extra articular manifestations of nonspecific symptoms of inflammation. So think about that. How do you feel when you're in an inflamed state? You can have low-grade fevers, you can have a poor appetite, you can have muscle weakness, malaise, fatigue, but those with rheumatoid can have other things like firm bumps in their tissue. They can get skin around pressure points such as the elbows, these weird bumps that sit there, and they can get these rheumatoid nodules in the lungs, heart, and sclera of the eye. These are rare, but they can happen. Also, the real worry is that the systemic problems include our increased risk for heart attack and stroke. We can have anemia, interstitial lung fibrosis, and the pleural effusions, which we've talked about. You can get Felty syndrome, which is a triad of rheumatoid arthritis, splenomegaly, and granulocytopenia, which can be deadly. Typically, we need to have confirmatory blood tests because we're going to be able to see the ACP and the rheumatoid factor, or the CPA. And then also, if you're checking x-rays and those things, we should start to see some changes. Next, I'm tying this in here now about treatment, because when we move on to pharmacology, we'll be talking about the treatment of rheumatoid arthritis. So if we understand these previous slides of how the formation of these issues occur, then when we start to talk about drug management, we're going to be targeting some different areas. And that is your short rheumatoid arthritis.